most of you already know this because you're part of our membership, but this is a list of folks who are involved in our leadership council. If any of you are looking for introductions to any of these folks, let us know, because as part of the membership, what we really want to try to do is connect people with each other. So if there are executives or folks here that you'd like to be introduced to, just give me a holler, or Amy or Claudia, and we'd be happy to introduce you to other members to help connect you. Next slide. I think most of you know what our mission is. It's to convene executives, identify best practices, and figure out how to transform healthcare using technology and innovation. Next slide. And our current area of focus, you guys know, we've always looked at interoperability, privacy, security, analytics, and value-based care. I mean, these are the topics we generally are working on month to month, week to week. And we are still working on those topics, but we're really looking at things right now in the immediate future through a COVID-19 slant. You can go to the next slide. And we launched a whole series of these virtual lunches, which are smaller meetings and really discussion forums. We've also launched a privacy and security series. Alice Leiter, our VP of Privacy and General Counsel, is heading up, featuring a whole series of different privacy speakers from around the industry. And they're going to be talking next week about some of the changes that are taking place right now, and that should be a great session with Julie Barnes is going to be joining us then. And then April 21st, we've got another session talking about HIE and how that's changing and overcoming challenges during this pandemic. And then we have another one set for April 23rd. We're going to be talking about telehealth and reimbursement. And I actually know, and Claudia, we've got about 2 or 3 other ones that we just don't have a date or a title for yet, but you'll be seeing those pop up as well. If there's something that you're interested in, or a topic that you'd like to speak on that you think we haven't really explored yet around COVID-19, please reach out to me, text me, email me. Give me a call, or Claudia or Amy or Catherine or anyone. We're really trying to just be as available and provide a forum for our members to speak with each other and communicate and share their experiences during this time. That's really the role of our organization, and we want to promote as much communication, disseminate information. If you've got something that's really working well, or you think that there's something that could help others right now, please let us know so that we can share that. Next slide. There we go. So Catherine, did you want to take us through kind of a little bit, just kind of a general overview of what happened?
Yeah, it seems like a long time has passed since Congress first passed the first coronavirus funding bill, the supplemental appropriation legislation. To think about, that bill was $8 billion to the third package, which was $2 trillion. It's kind of crazy to think how much happened in just a few weeks. And now that we're seemingly in a little bit of a lull in the legislative front right now, we thought we'd take the opportunity to go over what's happened so far and what we think might happen next. So I think what has gotten the most attention out of this legislation so far is that both the first and third legislative packages included significant health provisions, including authority for the HHS Secretary to waive Medicare telehealth restrictions. We're going to send a couple of additional fact sheets out to registrants so you can have additional information. One of them is the eHI Explains CARES Act, which is a 2-pager we put together of all of the health IT related provisions in the bill. I'm going to touch on a couple of them. Certainly there are others that you can take a look at, that 2-pager. And then we're also going to send around the CMS fact sheet on the telehealth waiver, so you can take a look at that.
And I'm just gonna tell you, I mean, this is a great resource that Catherine's mentioning here, the eHI Explains CARES Act. So if you have executives or folks in your organization that aren't really sure what it is and you're looking for kind of a quick 1 or 2-pager to explain to folks, this is a great resource to just send around to board members or employees who are interested. Go ahead, Catherine.
Great. Yeah, so after the first legislative package passed that gave HHS the authority to issue this waiver, and just to back up to give a little bit of background, which is kind of fun on how this all came to be, is about a year ago when there's a Congressional Telehealth Caucus, they had introduced a bill for a number of years called the Connect for Health Act. And a number of those provisions passed in 2018. And so they were looking to put more provisions together to introduce, and what happens usually is provisions get pulled off of the bigger legislation and put on some other moving legislation. And when I was talking to Congressman Mike Thompson's office, they had mentioned that wildfire relief and telehealth were their top two priorities. So then I got thinking and talking to some other people and realizing that there was this waiver authority that the Secretary has once natural disasters have been declared, that they can waive underlying Medicare statute. And so with the Congressional Telehealth Caucus, we drafted this provision that would give the Secretary authority to waive Medicare telehealth restrictions under any natural disaster that had been declared and public health emergency that had been declared. When all of the coronavirus stuff started, we kind of got together with all the stakeholders in the field and said that this makes a lot of sense for coronavirus, both to help treat, but also to keep people out of the emergency departments and out of physician's office, and to limit in-person interaction. Congress agreed and unfortunately didn't give us the full authority for the overall waiver. They limited it to this particular public health emergency. But it allows for reimbursement for telehealth services anywhere, not just in rural areas as had been in the past. Patients could be at home, not in providers' offices. And also they issued a couple of other enforcement discretion, one of which is that patients and providers can use any telehealth technology with audiovisual capabilities and not just HIPAA compliant technologies, which really helps people use the existing technologies that they have and not build new technologies right now. So going to the next slide. Touching on what's happened some more, I mentioned the 1135 waivers earlier. The Secretary has issued a number of 1135 waivers. It's in two categories. There are the broad waiver authority, Section 1135, of overarching Medicare reimbursement policies that can be Medicare and Medicaid policies that can be waived. And then the state can apply for additional authorities. And so a number of states have applied and been approved for additional authorities under the state waiver program. And the HHS has been approving those very quickly as states apply to give them the help that they need. CMS has also issued quality payment program hardship exemptions and additional hardship exemptions under hospital payment programs. And those are broad waivers that basically require no reporting for this year at all. Really focuses providers' attention on treating patients right now. Back on the telehealth side, the DEA has also issued flexibility regarding prescribing of buprenorphine for treatment of opioid use disorder. There are treatment programs that are via telehealth for opioid use disorder, but previously there had been regulation that it would require an in-person visit before prescribing. The DEA has issued flexibility on this. Also, ONC has put out the testing ground for interoperability proving ground, where different states or actors that are doing related to COVID-19 are testing different exchange and interoperability platforms. They can post that on the ONC website, and others can look at what people are doing to see if they want to replicate within their own systems or within their own state. On the privacy front, I will make a plug that we're going to be going over this much more in depth next week on our privacy and security webinar series. So if you're interested in that subject, definitely go to our website and register for that webinar. But OCR, which enforces HIPAA, has issued a notice of enforcement discretion for business associates, saying that if business associates are acting in good faith, they can disclose information, personal health information, to public health authorities during the COVID-19 period. Okay, what's next? So I think everybody has probably seen that there is going to be a fourth, probably more legislative packages from Congress. I think what I've heard is that a fourth package will likely include additional program expansions for what's already been passed in the first three. And then a fifth might start looking at new opportunities and what are the lessons learned from this, from the pandemic, and what can we do to strengthen programs and to create new programs moving forward. I think there's also the chance that because this legislation is likely going to be the only thing moving this Congress, that we'll see more and more non-COVID related provisions being put into these packages, because there are programs that are expiring that need to be renewed this year. For example, in the last COVID package, the third package, there were a number of Medicare and Medicaid extenders that passed in that legislation because they were going to expire by the end of May, and there was no other legislation that was going to be passed before then. So you're just going to continue to see more programs that need to be funded by the end of the year that will just need to move on a COVID package, even if it's not a COVID-related program. And then what's been swirling this week is a delay in the CMS and ONC interoperability information blocking final rules. Those were published at the beginning of March, or not published, excuse me, they were released in the beginning of March. They have not been published in the Federal Register yet, which would set the time clock for enforcement. Some of the enforcement on those rules start within 6 months of publication. So quite a quick timeline for vendors and for providers that are pushing on treating patients right now, quite frankly. And I think what we've seen, what likely will happen is HHS will issue enforcement discretion on those rules likely this week to give people more time for compliance. It doesn't mean that a delay in these does not mean that interoperability isn't important right now. I think this just highlights that interoperability is, of course, really important. It just focuses people's attention on the priority right now, which is treating patients. You know, of course, a quality payment program delay doesn't mean that quality healthcare isn't important. It just means that we need to relieve burden from providers somewhere, and this was a way to do it. And then I think we could also see additional waiver updates on the CMS telehealth waiver. The CARES Act included additional authorities around providers and technologies for the Secretary to waive basically any underlying statutory prohibition on reimbursement for telehealth services. So there are things that other organizations, including eHI, have been asking for, including flexibility on reimbursing for audio-only telehealth if audiovisual isn't feasible in areas of low broadband, or if a Medicare beneficiary only has a landline, for example. They also could expand telehealth to additional providers, so allow additional providers to bill for telehealth services like physical, occupational, speech, language therapy. They opened up the codes in the last update to allow for therapy services, but they didn't expand which providers could bill for those services. And then also the CARES Act added federally qualified health centers and community health centers as distant site providers of telehealth so that they could bill for telehealth services. And so hopefully we'll see another update to just continue to expand telehealth and expand access to care. And that is all I have, Jen. It looks like we have one question from the audience. If Claudia can unmute Jen.
I'm unmuted. Looks like we've got a question from Mark Siegel too. So Claudia, if we could unmute Mark and get him first, and then we'll jump into our own questions. That would be great. Mark.
Yeah, hi. Great presentation, Catherine. So nice to see you and Jen. I hope everybody's doing well. So kind of two questions related to what you touched on. On the enforcement discretion, could that operate where they publish the rules, and obviously those various clocks start ticking, and then they separately publish? And again, I don't know if that has to be, through Federal Register notice and comment enforcement discretion, or would they do de facto enforcement discretion by just holding on the rule publication? And then I'd say a parenthetical to that one is, could they be sort of granular in the enforcement discretion? In other words, hypothetically treat developers differently than HIEs, for example. So I've got one other after that, but I'll let you address that question. Then I've got another quick one.
Thanks, Mark.
Yeah. I don't know for sure. My best guess is that they will issue a separate notice of enforcement discretion, as they've been doing in other areas, because I think the rules have already been sent to the Federal Register for publication, and I don't think that they can take that back. So I think it would have to be a separate issue of notice, a separate notice of enforcement discretion. If I were to guess, I think it would be a pretty blanket, as we've seen with the hardship exemptions. The hardship exemptions on the quality payment program just say, if you don't report by April 30th, you don't have to report for the entire year. The entire reporting year is a wash. I think that they could be granular, but if I were to guess, with how fast they're having to put this out, I don't think that they're going to do that.
Okay, thanks very much. No, that makes sense. And then just the second question, you alluded to it in the telehealth, kind of the further changes. I'd say from personal experience with friends and family members who are particularly doing psychotherapy and similar kinds of telehealth services, that the phone only, and I know the American Psychiatric Association has pushed that. I think that becomes really critical. You get into patient preference issues. The other thing that I've seen is, in addition to just, there's general unavailability of internet, but with everything being stressed, we've all been on Zoom calls that fail. In any given instance, you can have a situation where the Wi-Fi in a house fails, or there's just a lot of people using, the bandwidth in the area. So, at least I would say for psychiatry, but my guess is for more general, that if clinically sort of audio only can work in this emergency, it definitely seems that ought to be considered to be permitted, because, there's just so much use of it right now, and so many different patient scenarios that are sort of hard to plan for. So it would be both encourage you to pursue that, but interested in your thoughts as well.
Mark, let me just piggyback on that, because we had a webinar yesterday on telehealth, and a couple of the doctors also mentioned how helpful the audio was, and that, being able to actually finally bill for these consults or visits, basically, over the phone, would be really critical. I mean, it seems like it's been long coming. So I think that, and we've heard this also from several of our members in rural areas who are dealing with broadband issues, but I think you're right in terms of patient preference, Zoom crashing, Wi-Fi issues, and I know Catherine's been pushing hard on this, and it's something that we're certainly exploring. But Catherine,
I appreciate that. Thank you.
Yeah. Catherine, anything?
Yep. No, I think that is right. And I think that I think it could be a little bit of a stretch for CMS because they continue to open some more specific telephone-only codes. But I'm hoping that maybe a reasonable compromise is for them to somehow allow it if audiovisual isn't feasible.
Yeah, thank you.
Yeah. You know, Catherine, just piggybacking on yesterday, there were other questions about telehealth that came up as well from some of the physicians about, you know, kind of the federal legislation. And one of them that keeps coming up over and over again is this idea that federal regulations were going to overhaul the state provider licensing and make it easier to treat patients across state borders. And so, you know, we've heard they're kind of not enforcing this as much, but I guess, can you kind of explain why it didn't happen or what what you're hearing in terms of this issue?
Yeah, licensure is an issue that's very complicated, one that I've worked on for a long time. Just for background, providers are licensed at a state level, and in order to treat a patient in a state, they have to be licensed where the patient is. So obviously, in a telehealth scenario, that can be limiting because you might not know where your patient is. You would have to get multiple state licenses, et cetera. And so when all the telehealth opened up, people said, well, this is all great, but we still have to get licensed in all of these states. HHS can issue, and they did issue, a waiver that allows for Medicare reimbursement regardless of where the provider is located. However, there are still state practice of medicine laws. So state practice of medicine laws still apply. And so you cannot legally practice medicine in a state without a license, even if you can get reimbursed for it for Medicare. There is no national practice of medicine laws. So even if the HHS secretary did have the authority, which is questionable if they have the constitutional authority for preemption here, that there's no national practice of medicine law. And so which law would you follow? Would you follow the law of the state where you are in? Would you follow the state where the patient is? It's really complicated. Not to say it couldn't be done, but in this short time period, it probably couldn't be done. And so instead, the HHS secretary sent a letter to attorneys general and to governors of states, urging them to pass laws and pass regulations to amend their state practice of medicine laws to allow for other states, providers licensed in other states to practice in their state. And a number of states have done that to allow for that flexibility. But it's something that has to happen at the state level right now. And I think moving forward, as reimbursement, if this continues, reimbursement continues to loosen, it's going to be something that continues to come up at the national level. Where do we need national legislation? Do we need more mutual recognition compacts like the nurse licensure compact, or a driver's license compact where you're licensed in one state and could drive anywhere? That's how the nurse licensure compact works. You know, unfortunately, there is a medical licensure compact, but it's not mutual recognition. The state regulatory boards, for the most part, are required to be self-funding, and they make their money off of licensing fees. So it's a little bit of a catch-22.
Yeah, I mean, and what we heard from the doctors yesterday was just that several doctors we talked to yesterday were actually in Texas, and Texas was still being very strict about it. Whereas
there was a
other
big Texas lawsuit on that.
Yeah. So, but then, you know, another provider brought up the point, well, basically, if you're getting reimbursed through Medicare, you know, how would they, you know, somebody would have to there'd have to be a complaint and someone would have to investigate it and all of this. So it's not, there isn't really a bureaucracy behind it. But so it'll be interesting to see, which I guess kind of leads me to another question, which is, you know, this whole public health emergency has caused us to all of a sudden look at all these different telehealth changes. And, you know, a lot of people have been pushing this for years and years, and it seemed like this was the what do they say? Never waste an opportunity, a crisis.
Yeah.
um, so this was really the crisis that created a lot of opportunities for telehealth, and that we've been pushing for so many years. So I guess, do you think that a number of these changes are going to be permanent beyond this emergency? I mean, what's kind of your best guess in terms of, are they really going to roll these back once they start allowing them?
Yeah, I go back and forth on that question. It's a very good question. I think that in terms of what the public is aware of and what they want, I think hopefully there will be a shift, because, you could make the argument that one of the reasons that this virus did spread so quickly is because, or why we didn't get a handle on it sooner, is that our healthcare system is still very much based on in-person care. And I hope that now that hospitals and providers and patients have had experiences with telehealth, that there will be more of a groundswell to make changes. It will require, if we want more Medicare reimbursement after this public health emergency, Congress will have to pass additional legislation to allow for that. I've always said that, it's not a matter of the technology. I think the telehealth has always been a bipartisan issue. It's just a matter of making it work within our current payment systems. And it's difficult when you still have a fee-for-service system to add any service, not just telehealth. I mean, people have been fighting to add a lot of services to Medicare, dental services, vision services. It's not easy. Especially when the Congressional Budget Office has to score everything. Increasing access or adding services costs money, and that's where you kind of hit the roadblock in Congress, is when stuff costs money. Obviously, if you're spending $2 trillion, money doesn't really matter, and so that's why we were able to get some of these changes. But even in the first bill, that was only $8 billion. Our tiny little Medicare telehealth waiver scored at $500 million, which is just drops in the bucket, but that's all they were willing to do at that point. And so I think what we're going to need is a lot of data coming out of this in order to make the case to Congress, because we've had a chicken and egg scenario for so long of Medicare says, well, you need Congressional Budget Office says, well, you need Medicare data in order to make a comparable case to say that telehealth saves money for Medicare patients, because they're different. They have more comorbidities. They're older. And so now we'll have actual Medicare data, which is like the gold standard. And so I think this can only be good for making our case for more changes.
Yeah. Just to add to that, one of the things the physicians mentioned yesterday was that, now that patients have had a taste of this, they're not going to want to go back now that they know their doctors can do this, and that it's going to change healthcare delivery in that, now telehealth is really going to be table stakes. Like, if you want to be a clinician at the table, you're going to have to offer some sort of telehealth services. Now that people know this is out there, it's easy. They don't have to leave their home. They can do it on their phone. So one of the things that I thought was interesting that was that HHS also loosened restrictions for patients who are getting home health care and hospice and home dialysis. So I'm curious if you can talk a little bit about those changes, because I'm wondering if we're going to see ultimately some changes in care delivery because of that as well, and those changes. So could you talk a little bit about kind of those other restrictions that have been loosened for patients?
Yeah, a couple of things. So in the 2018 legislation, Congress passed authority for end-stage renal disease patients to receive their monthly check-in visits via telehealth. And so that required, though, an in-person visit for basically recertification that they still need these services every 6 months. Hospice care and home health services have the same requirement around an in-person visit for recertification of those services, because in order to receive those services, you have to be certified as clinically necessary by a provider. And so HHS waived all of those in-person requirements and said that you can now provide those via telehealth to limit exposure.
And then on top of that, how has HHS considered the use of remote patient monitoring devices, both for tracking symptoms and tracking symptoms of COVID and other conditions, to make sure that only those who actually need to be seen are scheduled for an in-person appointment? You know, making sure, again, reducing risk and spread of the virus, so only people who go in are the ones that actually have to go in.
Yeah, and that's a good question, because often remote patient monitoring gets lumped in with telehealth, but in the terms of CMS regulation, they are separate services. And CMS has also added flexibilities for remote patient monitoring. They've said that they can be provided. Previously, there were restrictions on they can only be provided to established patients. You have to provide them to patients with a chronic condition, more than one chronic condition. So there are still restrictions. And so they've waived all those restrictions so that remote patient monitoring services can be provided for new and established patients. They can have both an acute and a chronic condition, or a chronic condition, excuse me. So basically allowing them for people who are experiencing coronavirus. And they've specifically said that they can be used to monitor a patient's oxygen saturation levels, so a pulse oximeter at home, to really watch for if there are dangerous drops in oxygen levels that would require a hospitalization. And so I think that there are going to be additional uses of those services at home, hopefully.
Mm-hmm. And I guess you'd just be guessing on this, but how long do you think these waivers are going to last?
Well, they statutorily only last until the public health emergency period ends. So once HHS lifts that public health emergency declaration, then that would go away. I don't know when that will happen.
Yeah.
So at that point, like I said earlier, it would require additional congressional action to remove those Medicare telehealth barriers that have been there for years.
Yeah. And I just want to remind folks, if you have questions or comments, please raise your hand. We welcome your comments and questions as we go through this. Can you talk a little bit more about the quality payment programs, and the providers and hospitals are going to have to take any additional steps to qualify for hardship exemptions? I mean, I'm sure basically everybody would qualify for a hardship exemption right now. So what are you hearing about that?
Yeah. I think I mentioned this earlier, but basically, yes, every provider under any payment system right now is given a blanket hardship exemption. There's no application process. If CMS has said that if you have not reported any data by April 30th, you get an automatic hardship exemption, meaning that you don't have to report for the entire year and that you don't have a payment adjustment. So you're just paid at the Medicare fee-for-service rate. They have also, as of today, issued additional funding for those providers that are in the alternative payment model track to get them, because how alternative payment models work in a risk-bearing model is basically your funding is based on your performance for the year, and so at the end of the year you would get your bonus payment, or whatever 2% or 1% that you were withholding. And so those people who are advanced payment models don't have as much cash on hand, and so CMS just pumped cash out to them basically today to help them get through this crisis. And so, yeah, they're very broad, no application process. And I think that, I mean, I've heard CMS is just saying, like, what do you need right now? We'll get it to you.
One of the things that surprised me was actually a change to the laws regarding the sharing of substance use disorder records. Can you talk a little bit more about that?
Yeah, of course. And definitely, like I said earlier, register for our webinar next week on these privacy issues, because there are people that are talking that are way more knowledgeable about it. But yeah, the background on this is that the privacy law 42 CFR Part 2 has more restrictions on sharing than HIPAA does. And so when the opioid use disorder crisis hit the country, a lot of providers and a lot of stakeholders were saying, you know, this law is prohibiting us treating our patients because they're required an additional consent for sharing of substance use disorder records. And a lot of terrible things are happening. There were people who were prescribed opioids in emergency departments that went in for a arm fracture, for example, and they had history of opioid use disorder they weren't currently using, but then the provider didn't know they had a history, so they were prescribed opioids, and they take the opioids and then unfortunately usually have an overdose. And so there was just this barrier, and had been fighting for a number of years. And this was one of the provisions on the bill that was a kind of a moving vehicle type of situation. The stakeholders on both sides of the issue, the more privacy-focused groups that didn't want the law to change to protect sensitive information, and the people who wanted the law to change had finally reached an agreement that you could issue a one-time consent for sharing of substance use disorder instead of consent every time for sharing for different providers. And so they had reached an agreement at that time, and this was legislation that was moving, and it got put on that moving legislation. And I think it also, you know, there are a lot of people right now, I think it can be COVID related. There are a lot of people right now that are seeking care outside of their normal methods of care. A lot of people going to the emergency rooms, a lot of people having to make decisions about their care outside of their normal providers that they're seeing. And so I think sharing of information is even more important, as I mentioned earlier. And so I think it is COVID related, but I also think it's timing related.
And I think one of the things we'll talk about on Tuesday at that webinar looking at privacy is whether or not, you know, what's the impact of all of these policy changes in privacy right now? Are these going to get rolled back? What impact's that going to have on really protecting consumer privacy? You know, are these going to stay as is? So yeah, it's a really interesting conundrum. Really looking forward to that on Tuesday. I know you're going to be there, and Alice Leiter as well. And so hope that you folks can join us for that as well. One thing that you already kind of mentioned earlier, or I guess implied, was you said about HHS delaying perhaps information blocking and interoperability rules given the pandemic. So what your best guess, it sounds like you were kind of leaning towards probably a delay.
I think so. Yeah, like I said earlier, I think that it was the release of the rules at the beginning of March was very optimistic. I think at that time, nobody really knew the scope of this crisis. And I think the administration wanted to put things out that were non-coronavirus related. And there was obviously a lot of focus on patient sharing of information, which had been a priority of the administration for a long time. And I think they wanted opportunities to talk about those provisions. The plan was the plan was, and I have now confirmed this with CMS officials who can share the information now, that the president was going to announce the release of those rules the Monday of the HIMSS conference. Obviously, the HIMSS conference got canceled, and with it, the announcement, but the release still went forward, and they're out there, but I think quickly there was a realization that it wasn't the right time, and that they are going to need additional flexibility.
Yeah. It's interesting. So when do you think we'll hear something? Do you think we're gonna, you know, there'll be a notice put out, or you think, what's kind of your best guess in terms of when we'll know something?
Yeah, I think multiple HHS officials now have said this week.
Oh, okay. Well, we'll see. I know they keep they have all those webinars planned, so.
Yeah, I mean, I think that education will still go forward, but you know, who's joining those webinars right now?
Yeah, yeah, definitely. So if any other folks have questions or comments, so what do you think is going to be on the agenda? Basically, just COVID-19 for the rest of the year, Catherine? Or
I think so. We just keep hearing more and more about there are going to need to be additional funding for the programs that were in the last package, the small business programs, and I think there are just going to be more and more COVID-related policies coming out. I think that is going to be it, and I'm more curious to see how these policies shape the discussion moving forward.
Yeah. Well, I know Catherine leads our policy steering committee, which is actually meeting today, and I know they're going to start talking about the fourth package or asks or thoughts about that package. So if there's anybody on the phone or any members on the phone that want to give Catherine and the policy steering committee any feedback about things we should be promoting or asking for in that package, we would love your feedback or thoughts. I know, Mark, you mentioned the telehealth earlier. I know that's one thing we're thinking about. And the broadband is another, I think, and certainly if there's anybody else on the phone who wants to share anything that they think is really important that eHI mentioned in terms of that number 4 package, please let Catherine know so we can make sure we're representing everybody with that. So we would appreciate that. Catherine, anything?
Well, the other thing I'll add, it's very interesting for lobbyists to figure out how to keep doing meetings and keep talking. I've never had a scenario where I can't go in and have an in-person meeting, so this is just crazy. So if you're in the same position, anybody on the phone, and have best practices, let me know, because it is an unheard of time for a lot of industries, including lobbying.
So are congressional staffers Zooming, or are they just doing phone calls?
I probably both. I don't know. I think we might have some congressional staffers on the line right now, so I'll stop talking.
We would love to know. So anybody who's on the line, let us know if you're open to Zoom. We appreciate it. Yeah.
Yeah. No, I think we'll probably start ramping it up when the 4th or 5th package starts going through. At this point, at the first 3 packages were just like emails and calls and all of that. Was just like, things coming out so fast and things changing so fast, and oh.
Yeah, everything's really been happening at lightning speed, which is very different for Washington. So
yes, yeah,
getting in there, but it's been good. People are responsive, so that's great. So, okay, well, any other comment? I know Catherine's always open to comments. If you don't want to talk online or out loud, feel free to reach out to us. It's Catherine at ehidc.org. I'm Jen at ehidc.org. And again, we welcome all your comments and questions. This has been great, Catherine. I think it's good just to let everybody know what we're thinking and guessing. And
yeah, and we're also hoping to have another virtual lunch next week. If you guys haven't seen the DoD TATRIC program, Telemedicine Advanced Technologies Research Center, I think what TATRIC stands for, they put out a couple of different notices of funding for telehealth programs. And so we're hoping to have the TATRIC folks come on and give a presentation on their emergency defense telehealth network that they're looking to put together. Just waiting on final confirmation and approval from headquarters. DoD has a approval process.
yeah,
what
is
can you
that
do?
a week from Tuesday? Is that Tuesday, Catherine?
Yes, it's supposed to be the 14th, and so I'm just waiting for final confirmation, and we'll send that out. And then I'll send an email to all of the participants today with slides and the 2 PDFs I mentioned, and then my contact information, of course.
Yeah. So thank you, and I just want to tell everybody again, we're thinking of everybody out there. We hope you're healthy and staying safe, and we're out here in virtual Zoom land. Anytime you want to reach out, we're available, and we're thinking of all of our providers and members out there on the front lines, and we appreciate all their heroic efforts. We know this is a really challenging time for everybody, and we want to be here to support you. So if there's anything else we can do to support you, if there's information you're looking for, that you haven't heard about, please reach out to us and let us know. This is really, we're going to try to be as effective a forum as we can be to try to share information. So please reach out. And thanks for joining us today. We'll see you next week for lunch.
Thank you.